Welcome to this Black History Month special. As you all know, February is Black History Month, so we're very proud to bring you this programming, which is regarding a very important topic between a collaboration between SUNY Downstate and the university in Rwanda, Kigali, Rwanda. So the session title is called Decolonizing Neurosurgery in Black Communities, a critical conversation about race, ethnicity, and community empowerment in neurosurgical inequities. I would like to, welcome our speakers, Dr. Ernest Barthélemy. He's a medical doctor who was trained at Mount Sinai. He later on did his neurosurgical residency, at Mount Sinai, and then he went to the University of San Francisco, California, San Francisco General Hospital. He did fellowship training there, and following that, he had additional training in public health. He's a global health expert in neurosurgical diseases. He's a very busy person when it comes to global health, health equity, and health disparities. Currently, he's serving at Downstate as the chief of the Division of Neurosurgery. He's also assistant professor of surgery in the Department of Surgery, Department of Neurology, and also Department of Orthopedics. He's also assistant professor of public health in the School of Public Health at SUNY Downstate. So he'll be representing the SUNY Downstate perspective, but he's going to be talking more about his experience, the American, Haitian perspective of neurosurgical diseases around the world. Our second speaker is going to be Claire Karekezi. He's also a medical doctor from Rwanda. He's a neurosurgeon who I got to know, trained in Morocco. He did his neurosurgery training over there, and then following that, he had training at Harvard University and many other places where he, got a lot of experience. He's now running the neurosurgery program, the only female neurosurgeon in Rwanda right now as we speak. She's a senior lecturer at the university in Rwanda, and also the neurosurgical attending in the Rwanda Military Hospital in Kigali, Rwanda. So those are our two distinguished speakers. My name is Dr. Moro Salifu. I am I'm professor and chair of medicine at SUNY Downstate. I'm also the director of the Brooklyn Health Disparities Center, where I have spent over 15 years of my time doing health equity work and health disparities research work with the NIH, the National Institutes of Health. So together, the premise for this conversation comes from a very outstanding collaboration between Dr. Barthélemy and Dr. Karekezi, who wrote this very, very important paper published in PLOS ONE journal, and it's entitled Historical Determinants of Neurosurgical Inequities in Africa and the African Diaspora, a Review and Analysis of Coloniality. So how does colonial influences impact training in general, and especially in neurosurgery? And how can we break those barriers of colonialism in order to impact care for patients with neurosurgical diseases? So today we are going to have some of the answers. I'm sure we have a lot of questions. You all have questions to ask about this topic, but I'm sure they are all prepared to respond to how colonialism has impacted training of professionals in neurosurgery, both in the United States from the health equity perspective, and also in Africa from the health equity perspective, and also the care of patients as well in these regions. So our first speaker, each of them would have 15, 20 minutes to speak. If they overshoot, it's not a problem because we have an hour and a half, but each of them will have about 15, 20 minutes to speak. And then we will have questions. I will moderate the questions, and we would have, it's a hybrid session, in person, and also there are participants on Zoom. So I'll be taking the questions as they come along, and I'll pass it on to the speakers, and we'll try to get clarifications on this topic, which is so important on how we move forward with making sure that we have enough people in the field of neurosurgery as a health equity issue. So, to that said, please welcome our speakers. So from Zoom, we have Dr. Claire Karakezi. We're so happy to have you. Please tell us a little bit about yourself, in terms of why you chose to be a neurosurgeon, and then you can go through your slides, please.
Great. Thank you so much.
Your story, basically.
Yeah, thank you, Ernest, to have invited me to have thought about this conversation. And so it's an honor and it's a pleasure being here with you all today. So as you said, my name is Claire Karekezi. I come from Rwanda, Kigali, Rwanda. So I have a long story. I basically grew up in Rwanda. I went to primary, secondary school here, and I did my medical school here as well. So when I was in medical school, I got an exposure to neurosurgery. So I was doing a rotation outside in Sweden, and that rotation kind of changed my whole world, because from there, I was just thinking I'll become a neurosurgeon, and that was 2007. So to tell you more, in 2007, Rwanda had barely one Rwandese neurosurgeon who just came back from training abroad. We had almost one CT scan, no brain MRI, and the little neurosurgical care that was being provided here locally was done by foreign doctors who came to help, in some cases, but there was no neurosurgical care given on the ground. So I am here, there's no neurosurgical care being given on the ground, and I'm dreaming to become a neurosurgeon. An impossible story. So, it goes from searching to trainings where I can go to train, and that's how Morocco comes in, and I'll be talking about it in my slides. But basically, that's how I went to Morocco, because many people ask me, how did you end up in Morocco? So I ended up there. I did my residency for 6 years, and then that opened many doors, and I did short training at the Brigham and Women Hospital, and then I completed my clinical fellowship at the University of Toronto. So in 2018, I came back to practice here in Rwanda. So basically, I've been practicing for the last 4 years. I initiated the neurosurgical department at the Rwanda Military Hospital, and I've been, going about many challenges that we'll be talking about, but very happy to serve my community. So it's an honor and a pleasure to be amongst you today. And if you allow me, maybe I can go through my slides. Great. So today I'll be touching a little bit about global neurosurgery from the African perspective. And, I think the main purpose today is to end up talking about decolonizing global neurosurgery. So global neurosurgery will be the practice of neurosurgical care from anywhere that is provided to anyone from anywhere and in any circumstances. That includes, all the forgotten communities, which can include communities in LMICs and other not well-developed countries. So as we discussed, we'll talk more about it. I have no disclosures. So when global neurosurgery and global surgery started to be discussed, that was around 28, from 2016, that was global surgery, and then 2018, more about global neurosurgery. People went back and were looking at LMICs. So you see this map of Africa that shows almost, no light. So Africa had been left behind and had not benefited from the progress in neurosurgery in the last 50 years. So some of the factors were lack of financial resources, infrastructure. Some countries were not politically stable, and there were very few senior neurosurgeons practicing on the continent, and there were inadequate health planning. So neurosurgical care was a very big challenge for anyone. So the very first publications about this came out around 1998. This is Professor Abdsalam El Kamlishi from Morocco, who published one of the major papers that showed what's really happening in Africa. So that time in 1998, you see that Sub-Saharan Africa was counted to have about 615, about 565 neurosurgeons in the whole Africa, but Sub-Saharan Africa counting about 79. That was like almost 14% of all neurosurgeons that were on the African continent, and the rest were practicing either in Northern Africa or Southern Africa. So the middle had really been lacking neurosurgeons. So from his publication, he was able to start the conversation at the World Federation of Neurosurgical Societies. And people were arguing actually at that time, so is that neurosurgical care important in these countries? Do they have neurosurgical conditions? And he convinced them that, these countries have neurosurgical conditions and this country need neurosurgeons, so we should start training some of their doctors. And when you look at the background of most LMICs, especially countries from Sub-Saharan Africa, neurosurgery was not considered as a primary health care. It was considered sort of as a luxury care that can be provided to anyone who can pay for it and who can, travel to get that care. But the rest of the community who probably presented with neurosurgical conditions, they were forgotten. So many conversations, many questions arose, and some numbers kept coming. This is one of the latest reports trying to trace the current number of neurosurgeons in Sub-Saharan Africa. And you see that we counted in the whole Africa about 1,750. And again, most of these neurosurgeons will be practicing either in Northern Africa or in the Republic of South Africa. Then some countries really been leading in, starting local training, starting local colleges like Western Africa, the Western Africa College of Surgeons, which started training neurosurgeons, and the Morocco, that Professor Kamlishi with the WFNS, he started also a training. So there were scattered trainings here and here, and then numbers started increasing, and you see that up to now, some countries are still with not a single neurosurgeons, but numbers have increased. So if I talk about my country, I told you that before 2007, little is known about neurosurgical care, and the neurosurgery was provided by foreign doctors who came to help. One CT scan in 2007, one is neurosurgeon, and then we got our first MRI in 2010, and by 2011, that was the time I went for my training. But you can see that we only had 2 neurosurgeons for 11 million people, and there was no local training. So I had to go out to train because I had no opportunity to train locally. So in 2012, my colleagues who started the training here, and by 2022, we have about 6 neurosurgeons for 13 million people, and we have a couple of residents. So this is me, 27. I'm coming from Sweden. I have, many ideas. I'm a young, ambitious woman, and I want to be a neurosurgeon. This was almost an impossible mission, but I read about Professor Absalam El-Kamlishi and what he has been doing about training of other African neurosurgeons, and I started emailing him. So it took almost 4 years. So you can see from my me wanting to be a neurosurgeon in my fourth year grade of medical school, and me starting the training because I had to finish, and I worked almost 1 year and a half before I could join a training. And then I joined the training in Rabat, Morocco. So I stayed in Morocco from 2011 to 2016. So this program did not only train me, and I think that was a really good beginning of global neurosurgery. This training has contributed to train other neurosurgeons from various African countries. You can see that we all went back, and most of these guys became pioneers in their own countries. Here we are. So we are new in a new country. We're here trying to learn. We learned some Arabic. We are learning basic things that eventually helped us. For me, this training gave me many opportunities to be open to the practice of neurosurgery, what's being done, what are the opportunities to train outside. And then from here, I was going to conferences and I was having many opportunities. And I eventually ended up going for my short training in the US and my clinical fellowship in Canada. So from the well-established program in Morocco, I go to more comprehensive programs, I would say, because that's how it is in the US and Canada. And I was learning what I can take when I come back here in Rwanda. So I eventually came back in 2018. So I'll be talking about current neurosurgery training in Africa. We recently wrote this paper, I think 2022, and we're looking at training programs, what progress has been done. We found about 76 African training programs. So you can imagine from where we came from and from and to where we are now. And this program recruits up to 168 trainees each year. And currently about 22 countries have at least a local training program. And we have colleges that recruit neurosurgical trainees as well. So even if there is no standardized training on the continent, because we wrote another paper about it, we looked in the program, so what's being taught, is everyone teaching the same thing? Currently, there's no standardized training, but I think we're getting there, but a lot has been done. And then we wrote another paper with the young African neurosurgeons, looking at the needs of these young neurosurgeons practicing on the African continent. Actually, these young people are really being exposed to various neurosurgical conditions, but also being overwhelmed because they're still very few in their countries. And there's still some limitation like cadavericosis, more subspecialty trainings that are needed, and they want to learn and they want to be even more trained. So this is Rwanda as well. The training has evolved from 2007, 1 neurosurgeon, 2013 almost the 2 neurosurgeons started training. They took 3 residents who became the first 3 locally trained Rwandan neurosurgeons. So up to now, we have about 6 neurosurgeons, 6 residents, and we have the local training program and the COSEXA program. But so far, we do not offer any fellowship. So that's mainly a background about neurosurgery in Africa, training about neurosurgery in Africa. And I will now bring my talk about gender equity in training globally and in Africa. So if you pull out, this was a picture I pulled out from Google. If you write neurosurgeon, so you see it's, I'm not ashamed to say it's a young white male. So if you look at the numbers, in the US, you have about 46,000 anesthesiologists, about 25,000 orthopedic surgeons, but you don't even have enough neurosurgeons as well. So because you have about 3,600 from this paper. And when you look about these 3,600, where are they female? So the female counted about 8% of all practicing neurosurgeons in the US. And then when you look about Black female, where are they? Or even female leaders. So you have Professor Odette, who became the first full professor of neurosurgery in any program in the US, very recent in 2019 or 2018. And then you have Dr. Timmons, who became the first American Association of Neurological Surgeons president in 2018, since its creation in 1931. And Nancy, who became the first woman to match at a neurosurgical resident at Johns Hopkins Hospital. So it's not only Africa, it's about like equity everywhere. So the progression, you see that Alexa Kennedy became actually the first Black woman neurosurgeon trained in 1981. And the first male Black was Clarence Green, who became the first neurosurgeon, Black neurosurgeon trained in the US in 1953. And then I talked about Alexa Kennedy and Dr. Odette, who became the first African-American tenured professor of neurosurgery in the United States only in 2018. How about trainees like Ernest, who come from other countries? There is a big name, Dr. Latunde Odeku. He was the first African neurosurgeon to be trained in the US. He finished his training in 1961. And then lately we've been seeing in all our societies, we have Black representation, gender representation, there are diversity groups, and I think things are evolving. So we wrote this paper in 2021 about the history of African women in neurosurgery. We're interested in knowing how many are we and how represented we are. So we are not so many as well. You can see that I think we found about 200 and something numbers. And most women actually were in Northern Africa. So Algeria counted for the big number with about 135 female neurosurgeons, comparing to the number of male they have. But also I'll be talking about it. When you look about these female neurosurgeons, what do they do? Are they evolving? What's the post-training status of this female? Progression is a real problem. So you have a big country like Egypt, which has, I think, the highest number of neurosurgeons in Africa, yet only 3 women neurosurgeons. And all other countries, they have 1 female, 2 there. So we're not so many women neurosurgeons in Africa. So these are the pioneers. They're all first female in their countries, including myself. And when we looked about academia, all the full professors, they are all from Northern Africa. So we had few associate professors, and myself, a senior lecturer, and my colleague Beverly, who is an assistant professor at the University of Kenya. So in academia, we haven't progressed either. In leadership, these 2 women became the first female president of their societies, neurosurgical societies, and have been leading the African Women in Neurosurgery Committee of the Continental African Continental Association, Continental of the Continental group that brings all the associations of neurosurgeons in Africa, and some of the other female who are young leaders with myself as well. So that's about it. That's about neurosurgery in Africa, female neurosurgeons in Africa, And I think as we go through global neurosurgery, we go through our honest story, and then I'll be happy to take some few questions at the end. Thank you.
Thank you so much, Dr. Karakezi, for a wonderful review. And thank you so much for all the efforts you are putting to lay the foundation for women in neurosurgery to actually see as a motivation to get into the field. We're so proud that you're able to lead that path, and also for your country and the continent in general. I'm looking forward to your contribution on how we're going to decolonize that, but that is going to come in the next segment. All right, so the next speaker is going to be our own Dr. Barthélemy. He's a neurosurgery chief at SUNY Downstate. He's going to give us a different perspective, the perspective from the Black, Haitian origin connection, and also that of SUNY Downstate. So Dr. Barthélemy, please go ahead.
Thank you. Thank you so much. And, you know, I'm so deeply inspired by Dr. Karakezi, as well as several of her colleagues who she named in the presentation. I've had the pleasure of getting to know the past few years. And gender equity in neurosurgery is so antithetical to the colonial legacy that it sits right at the center and at the heart of, you know, what I hope we ultimately get to talk about. So I'll introduce a bit about my story, and then perhaps get a little bit more into that. So I was born in Brooklyn, and this is, I have a copy of my birth certificate here from Brookdale Hospital, where, you know, so, and it's where, you know, it's one of the centers where I currently practice neurotrauma, and I frequently see, you know, Haitian families, you know, struggling with English and the health system, and I think, wow, this is what my parents were dealing with, you know, before I was born in that place. And as we all know, here in Brooklyn, there's a very, very strong presence of Haitian Americans and other Caribbean Americans. We serve a very strong immigrant community here. And you know, my story with neurosurgery, very non-traditional in many ways. I want to say straight away for people looking at these images that there is no political statement here, okay? But I had a non-traditional road into neurosurgery. I was actually a professional dancer, specializing in Afro-Cuban and Latin dances. And when I did my undergraduate studies at NYU, a lot of the work I did was in some of the anthropological and ethnographic context of the dances in which I specialized as a dancer. So neurosurgery ended up being my third career because I went from being a dancer to pivoting towards being a fitness professional and pursuing a master's degree in exercise physiology at Columbia to support my fitness career. But things started to happen during that phase of my graduate training, fell in love with the human nervous system. That's where I discovered that strength, the way I thought of it, was missing something fundamental physiologically. It wasn't just bone and muscle stuff. It was a neurological phenomenon, which makes perfect sense now when I think of people who become weak in the context of a stroke. And so I really discovered the human brain and nervous system during my graduate studies. And I had a mentor in that program, an autonomic physiologist from Belgium, and I think because of his own Francophone background, he took a liking to me for some reason, and so we would talk about where I was headed in my fitness career, and he sat me down once in his office and said, you know, I think your parents will thank me for telling this to you, but I think it'd be a waste for you to continue to pursue doctoral studies in physiology. You should be a medical doctor because, you know, you're not the typical graduate student who comes through this program. And so, you know, from that conversation, I started searching, and I came across this book, Gifted Hands, and which is Ben Carson's autobiography. And before getting into the story, what really struck me about it when I came across it in the bookstore was I thought, this guy looks kind of like me. He looks a little bit like me, and he has had an illustrious career as a pediatric neurosurgeon. So that was the first time I was able to envisioned that maybe I could do something like that. Maybe I could be someone like this in this rather racist society that I was growing up in. And I had a lot of experiences to inform, my read of American society as, as one where racism was a major part of the context. And so it was completely serendipitous and happenstance that in that same graduate program, Ben Carson happened to have been selected as the keynote speaker for my graduation. And I don't know if this was orchestrated by that mentor of mine, but he let me know as soon as that was confirmed, and so I had the opportunity to meet him in person. And this picture that we have, I've hidden it ever since his more recent political expression became widely known, and I thought, oh, I don't necessarily want people to know about this. But I'll never take away from him the deep inspiration of seeing someone who looked like me, who was a successful neurosurgeon and planted the seed of the idea that maybe this could be me. And I went on to read some other books about neurosurgeons, Harvey Cushing, the founder of neurosurgery in this country, and then Wilder Penfield, whose story really struck me because I thought, well, this guy is very different from Cushing. And if I had a chance to know both of these gentlemen, I feel like I would have gotten more along with Wilder Penfield than with Cushing. That was my read, reading those two biographies. And I'll have more to say about Penfield later on. But I did all of that even before starting medical school. So I was considering a career in biomedical research also, because I learned that research was a way to create knowledge. And that was an interesting new way to express myself creatively, right? And so I spent some time in the lab as an NIH prep scholar at Mount Sinai, which was a program that was designed to support the careers of future translational biomedical investigators from underrepresented minority groups. Okay, so this all happened, I would say, in the 2005 to 2007 period. I started medical school at Mount Sinai. Originally, I was an MD PhD student there, but then my second year of medical school, 2010, this happened, this terrible earthquake in Haiti, the epicenter of which was really right here, not quite in Port-au-Prince, but in this spot that those of you can see me pointing to, this red hot spot here. That's actually my parents' hometown of Gonguev, where I remember when I finally got to see it, the concrete was completely split open, and you look down and it was like you could see right to the center of the earth. And so there were many, many devastating ramifications of this earthquake, as many of us know. A lot of people discovered Haiti after this moment in 2010. Certainly had a major impact on my thinking. I went into medical school already thinking about neurosurgery for the reasons I've stated, but now I was thinking, how do I, how can I be of service in the country without which I wouldn't exist, right, in Haiti? And so this is where I started trying to think about global health and being of service in the global health space and doing it as a neurosurgeon, which seemed like a paradox to me and to others I started talking to about this. But I started asking some questions similar to what Claire had mentioned about the thoughts people had regarding the importance of neurosurgery in Africa. I asked them for Haiti. I thought, well, there are human beings in this country, so they probably need neurosurgeons. What do they need neurosurgeons for? How many neurosurgeons are there, et cetera? So these are the kinds of questions that started to guide my thinking, and I proposed a project to answer some of those questions to Mount Sinai's neurosurgery department. And they were intrigued by this, and so they gave me $30,000 to go live in Haiti for a year and try to find those answers. And that's what I did. I spent 3 months at a time in each of 3 major referral centers and surveyed all the patients coming through and learned that of all patients coming through these centers, I saw about 7,000 of them, and anywhere from, say, 15 to 19% of patients coming in had some sort of neurological disorder. The neurological priority was clearly stroke and cerebrovascular disease. The neurosurgical priority was trauma. In fact, over 80% of the patients showing up who needed a neurosurgeon to address some kind of a traumatic brain injury. So that stayed with me from this experience. In the background, I didn't get into this, but it's relevant. I had the opportunity to meet and get to know Paul Farmer, who was the individual who brought me to Haiti to help with the relief effort after the earthquake. I reached out to him having made contact at an earlier time, and he said, we would love to have a Haitian-American medical student who can speak French, Haitian Creole, who can communicate with these patients that all of our volunteer surgeons are flying in from around the world to help, but they can't speak to any of these patients, so maybe you can help to solve that problem for us. So Paul Farmer became an important mentor, helping me figure out what this career in global neurosurgery was going to look like. I ended up matching into neurosurgery at the same institution where I did my medical school training, Mount Sinai. So 2014 to 2021 was my neurosurgery training, but I had some fellowship experiences, both embedded and then following that experience. So the embedded experience was my first global surgery fellowship as a Paul Farmer Global Surgery Research Fellow at Harvard. That program enabled me to use the elective time I was offered in residency for my research to go continue building on the work I'd started in Haiti, which had only 4 neurosurgeons, and even still has only 4 neurosurgeons for about 12 million people, all practicing in the capital city, so leaving most of the country without a neurosurgeon. And I started looking at how to build professional community around advancing neurosciences generally and neurosurgery in particular there. I got my MPH at Harvard during that time, and then later after residency, I went on to do this neurotrauma fellowship at UCSF that I did because the thinking was, well, if neurotrauma is the #1 reason why people need neurosurgeons in Haiti, and I learned virtually everywhere else in the world, let me get some specialty training there so I can bring that to the global health space. But I also found there was a global surgery and health equity fellowship that was meant to complement clinical fellowships at the CHESA program. So I did a CHESA fellowship during my time at UCSF as well. That's the Center for Health Equity in Surgery and Anesthesia. And so that's kind of how I got started. And to the context of what we're talking about, decolonization and the colonial legacy, this is so important. So there were a couple of things that had me thinking about this as a rising global health professional committed to global neurosurgery. The first was the George Floyd incident and how it caused this moment of reckoning, not only in the United States, but I learned from my partners really globally that all of a sudden it brought back to the forefront how real the colonial legacy was. So real that people were still dying from this, not just in sub-Saharan Africa, right, in this so-called high-income country in the United States. And I know, knowing Haitian history very well, and Haiti is the first independent black republic in the world, and what that meant for Haiti in terms of how Haiti then suffered the consequences of being this country created and run by formerly enslaved people, surrounded by nations that would continue to practice the enslavement of Africans for almost another century, right? So if you read our paper, you'll learn about abolition, for example, in Brazil not occurring until 1888, right? So more than 20 years following the Emancipation Proclamation in the US. But this context of slavery is often either forgotten or not remembered to the extent that it should be, because it really makes a lot of what we're dealing with now make a lot more sense. And every single dot on this diagram is a ship full of human beings, okay? This is a great website, by the way, that has done an excellent job of documenting this history. So it starts there. Now, the American context we didn't get into as much in this paper, and it is not excluded. In fact, it is deeply included. And probably the American story, perhaps South Africa's story, these are stories that probably deserve a deep dive in and of themselves in a similar light as the countries that we introduced in the paper we published. But with the US, we have this Flexner report, which is a critically important turning point in medical education in the United States. So you want to recall that we're talking about half a century prior to the civil rights era. We are still in a context of segregation. We are still in a context of white cultural dominance in the US. And this gentleman of German Jewish heritage, Abraham Flexner, was selected after recommendation by Harvard University. And some contacts. He was the brother of Simon Flexner, who was a close friend of Rockefeller, so that was important from a structural standpoint. But he was asked to review the 155 medical schools in the United States and see what they were up to, what should continue, what should be shut down, et cetera. And part of what he decided after doing that review was, well, one thing that should be shut down is all but 2 of the historically black institutions training medical doctors. Howard and Meharry were the only 2 institutions that he thought were worth giving any resources to. So now you had the majority of medical schools at the turn of the century that were training black physicians shut down. And it was by this report where, you can read this report and see quotes, for example, on page 180, where he talks about the Negro in medical education. Talks about that the focus should be a substantial education in which hygiene, rather than surgery, for example, is strongly accentuated, okay? And so this report markedly shapes all of medical education and public health in the US for the rest of the century, okay? Why? Well, because of these structural factors, right? It's not just that an individual, writes this report that he was commissioned to write by the enabling money of the Carnegie Foundation, but it's reinforced by Rockefeller, who pumped $180 million into a general education board that was put in place to implement the recommendations of that report. And then the American Medical Association further reinforced this by reviewing medical schools and checking, are we carrying out what Flexner recommended in that report? So this was a very decisive factor in the context of many other things that are happening in the US around the same time period. Here's Harvey Cushing, who is celebrated as the father of American neurosurgery, and really neurosurgery around the world. And a couple of quotes that point to the era, not just the individual, right? And this is not to vilify an individual. We're talking about someone who lived in a period where the US was going to still have legalized segregation for another half a century. So that's the context. So in the context, it's less shocking to hear someone, write to Cleveland's director of public health. I'm sure that colored women would often make excellent trained nurses, but this will mean that colored men, who are their friends, will have to appear at the nurses' parties and receptions, and this would be absolutely disastrous to the whole social status of your training school. Or someone who would write a letter to his parents after working with an ape in the laboratory of the celebrated British neuroscientist Charles Sherrington and say, the ape was coal black. I don't believe you could have distinguished his ear from a darkie's. He smelled just like a dirty Negro, behaved like one, right? And you can read this in that biography by Michael Bliss, okay? And other such evidence of the racism and anti-Semitism that was common. Sure. So other things are happening in the country, separate but equal. I refer to the legalization of segregation in the Plessy versus Ferguson case. Plessy, by the way, was Haitian American. A lot of people don't know that. It was a Haitian, I believe octoroon may have been the term, because we were still in a period where the one-drop rule was in effect. So even one detectable drop of African blood qualified someone as black, right? In the development of the structurally racist context of the US. And many other things. I won't go into detail, but lynchings and things of this nature, this was very commonplace at the turn of the century when leading up to when the Flexner report was published and released. So it grounds us in what's going on. And it's not until 1954 that finally we break down that major structural barrier of the legalized segregation that was hurting the production of black physicians, right? So our first neurosurgeons, some of which Dr. Karakesi mentioned, they're coming up in this period. You'll recall I mentioned Wilder Penfield earlier. I read his book. So he's an interesting character also because he was the founder of the Montreal Neurological Institute, which was the first institute to train the first black neurosurgeons in the United States in a period when segregation was still legalized. So, Clarence Green and Jesse Barber and even Lloyd Days, okay, 3 of our first 4 African-American neurosurgeons in the US, they trained in Montreal. It's Dr. Odeku, who Dr. Karakezi mentioned, this first African neurosurgeon to be trained in the US, who came through right after Brown versus the Board of Education, and so had the opportunity to be trained at the University of Michigan. Okay, so finally we were turning a corner, we were entering the civil rights era. And then Claire mentioned Dr. Kennedy, and then there was also Dr. Hyde. These were the first 2 women who in the 80s became the first African-American women to be board certified in neurosurgery by the ABNS, the American Board of Neurological Surgeons. So for concluding remarks now, I'm going to bring us to the paper that we wrote and try to entertain some questions that we'll have. But I'll talk about the context here in Brooklyn, okay? So my data here is from the Brooklyn Community Foundation. So we're talking about a population of 2.74 million people in about 70 neighborhoods that makes Brooklyn the most populous and fastest growing borough among the 5 boroughs of New York. We're talking about a city that is the 2nd largest black population of any North American city at 730,000, larger than Atlanta and Detroit combined. We're talking about a place where over 1/3 of the residents were born in another country and speak over 200 languages. So 50% of households speak a language other than English. 1/5 of residents live in poverty. Most children in New York City live in poverty. And most public housing units in New York City, particularly in the Brownsville neighborhood, which has the highest concentration in the neighborhood. This is all relevant to Brooklyn, having the most children living in poverty, for instance, in New York City. That's all happening in Brooklyn. Okay, so with that context, we see that even if we think of the United States as a high-income country, when we look a little bit closer, that breaks down by city and zip code. And really what you have is a smattering of low, middle, and high-income countries sort of thrown together in this large landmass called the United States of America. Okay, and Brooklyn appears to be on the losing side of that equation, certainly if we're talking about it from the standpoints of the colonial legacy. So, here's some data, and we could obviously, go on and on about the epidemiology. I'm not going to go into detail on this. This is just looking at from 2015 to 2019, so pre-COVID, we're looking at the number of deaths, top causes of death in Brooklyn from the New York State Department of Health. Heart disease, always number 1. Cancer, number 2. So here you start to hone in on diseases for which the care of a neurosurgeon can become critically important as cancer goes to the brain and the spine. Unintentional injury, interestingly enough, becomes number 3 in 2019. And it's sort of moving back and forth, but we see it rising. So that's another way to think about trauma. And most death from trauma occurs as a result of a traumatic brain injury. So now again, we're talking about, do we have the neurosurgical capacity and related trauma care capacity to handle the results of unintentional trauma. Diabetes remains a high and important comorbidity for a lot of disease in virtually every category. And then interestingly, we see cerebrovascular disease like stroke show up in 2019 now as the 5th. So we have 1, 2, 3, 4. So 3 of the 5 causes, 3 of the 5 top killers of Brooklynites involve or require the care of a neurosurgeon and the care of a center with neurosurgical capacity. So that's the beginning of the global neurosurgery story for Brooklyn. And it means understanding what the burden of disease is, like these areas of disease, the capacity to care for those diseases, as I've listed here, as well as understanding the determinants of the disparities, many of which are rooted, as I've hopefully convinced you, in the colonial legacy here in Brooklyn as elsewhere in the world. Okay? So, and I'll end this segment here with this review by Robbins et al. That summarizes multiple papers demonstrating that black patients fare worse than white patients across some major areas of neurological disease: stroke, Parkinson's disease, epilepsy, etc. Okay? This figure from a paper published 2 years ago by Gabriel et al. Demonstrates that in terms of diversity in neurosurgery applicants, Black applicants are here down at the bottom. The trends remain low, and there's some suggestion they may be getting worse. So from that perspective, we have a crisis on our hands. The blue line represents white applicants. The orange line represents Asian applicants. Hispanic applicants sort of statistically intermingle with Black applicants here at the bottom. Okay? There are some opportunities that are coming about to try to fight some of this, and we can get into some of that. So a good friend of mine, Dr. David Paul, who published this perspective piece following the George Floyd incident. I've lifted some quotes from his paper and oriented towards some of the things we can do in a way forward in the way of decolonizing neurosurgery and decolonizing global neurosurgery here. Okay? So we can come back to that if it's relevant, and I'll stop at this page so we can go to some questions. But this page shows the pictures of all of our co-authors on the paper that we published. I was so excited to have my former professor from NYU, Dr. Sylviane Diouf, join us as the one non-neurosurgical member of our author group. She's a world-renowned expert in the history of slavery and the transatlantic slave trade, a Franco-Senegalese professor who most recently was a scholar in residence at Brown University, doing important research in this area. So thanks for your attention, and let's try to address any questions you have.
Wow. That was amazing review as well. Your story is also inspirational. I just, admire how you were able to, plow through your initial interest and then merge it, into neurosurgery and becoming a well-renowned neurosurgeon, and now collaborating with your colleagues in Africa to do more work on the global stage is really remarkable, and thank you for that. Both of you speakers were phenomenal. I think they've shared their stories. Now we are open to questions. But I want to make some few comments before we go into questions, which is that I was originally born in Ghana. So I have some little bit of, little drop of how, a colonial state actually emerged following independence. It is not really easy. The independence was meant to free people's mind and, the natives take control of their countries. But it wasn't, that was the camouflage. It wasn't that simple. A lot of the economic activity, a lot of the determinants of how a society is built and advances actually still remained in the hands of the colonial powers. It was very, and up to now, it's still very difficult to dissociate those two. And of course, if you are running your country, but your economics are dependent on another country, there is no way you're going to make it to full-fledged independence. So the political independence is completely different from the economic independence, and that is holding a lot of African nations behind. But the problem still remains that we have to find solutions to decolonize. We have to find solutions to break those barriers. And this is an example in one area of neurosurgery where, we have the first and only woman neurosurgeon in Rwanda. Just imagine that. So one barrier has been broken, but we have to break more barriers. Just look at the statistics from the United States. Very few neurosurgeons, black neurosurgeons, and even more fewer black women neurosurgeons in the United States. So there's a lot to be done in the area. I want to turn my questions to the speakers. Do you think that, and any one of you can answer, but let me ask Dr. Karekezi first. Do you think that solutions for Rwanda or Africa would be similar to solutions for United States as an example? Or are they going to be different solutions, whatever you think, yeah?
Yeah, absolutely. Ernest just, showed us that, within the United States, you have LMICs, actually. So you have people who are not benefiting from the neurosurgical care because they are in some disadvantaged communities. And that brings me to a recent published paper in the Lancet. I may put the link here. The paper is talking about reclaiming global health. And we've been focusing on, countries in Africa, countries in LMICs, where we see countries like the US coming to help us. But within the US itself, there are people who are not benefiting from global health. So I believe the solution within the US is going to be the solution within the African countries, within all the MICs. And that solution is, we're capable of taking care of our own, I would say, neurosurgical care. We may be few, but we need to increase the numbers. We need to work more. And when these high partners coming from HIC come to us, actually, we should see it as, they are partners rather than, people who are coming to dictate or to say, oh, you should be teaching like this, or you should be, doing like this. There are some realities which are not maybe similar to the US that people on the ground know more. And it's all about, partnering, having same views and working together. So I believe the solutions, whether within the US or whether Africa or Rwanda, they're coming from ourselves.
Thank you for that answer. Dr. Barthelemy, any opinion on that?
Yeah, well, first, I agree completely. There are obviously going to be differences. I would suggest that there are not going to be as many differences as we might think. And when we start having conversations with our colleagues in other countries and comparing notes, those are the kinds of conversations that enable us to discover what we share. In the paper we published, we highlighted that there's a lot that we share historically, even from places that are very, very far apart. And we understand the value of history in our ability to understand what we're dealing with in the present. So I have some specific examples. One popular example in the global neurosurgery space is endoscopic third ventriculostomy and choroid plexus cauterization. So Dr. Benjamin Worf, a pediatric neurosurgeon at Boston Children's, who spent a great deal of time working on neurosurgery capacity development in Uganda, ultimately began to innovate around that technique in a way that its benefit became rapidly evident in the US. And then it started to spark new attention and interest in the use of that technique here, based on an experience there. That story is not as shocking as it may seem, when you consider that really all that has to happen is a humanizing of people, right? So I think the history lesson enables us to discover who has been dehumanized, right? Who we fail to think of as sharing our experience of humanity, sharing the experience of disease, sharing the experience of poverty, resource constraint, etc. These are some of the barriers that I think we need to break down with our decolonization process, and that would let us mutually benefit from the solutions we bring to neurosurgical problems everywhere.
Thank you. The next question I want to ask the two of you, and I can start with Dr. Karakezi, is obviously you've made the point that we don't have enough neurosurgeons, let alone women neurosurgeons. You've made that point very clear. In Rwanda, as an example, do you think your training program is enough? And what international resources would you need if it is not enough?
Thank you. I'm looking back when I wanted to become a neurosurgeon. That's about maybe 14 or 15 years back, where we had nothing and where we are now. So even if we're few, there is a progress that has been made. We have this local training program that is recruiting. Actually, we have two women in the program, which means that these two women, if they come out, will even have more women because, as we become more, we are attracting more women. And we are also benefiting from regional programs. So we are part of the called COSEXA, is the College of Surgeons of East, Central, and Southern Africa, where the college has a training in neurosurgery as well. So people can be recruited through the COSEXA program and can be recruited locally. So I think Africans are looking for solution between themselves. And as Ernest is saying, even if we may, because, like neurosurgery is a discipline that relies on technology, and obviously high income countries are advanced, and, we have to agree they're advanced in terms of technology, but Africa is not left behind. We have brilliant people on the African continent. People on the African continent are the most young, promising generation. So I believe, in the coming years, we'll have these people generating tools that we use, and will not, be relying on tools we get from, the US or from, Europe or Asia, because, we're training people, but these people will eventually need tools to work, especially in neurosurgery. So we also have to come up with those local made solutions. But I think we are on the right track because, a lot has been done in the last 10 years, and I'm optimistic. Thank you.
Very nice.
We have a question from the chat. I'd like to direct.
Could he respond before we go to the chat question?
Sure.
Could you respond to that? In the United States, obviously the numbers are low. So in terms of policy, what can be done to increase the number of Black and especially women in neurosurgery?
Right.
In terms of policy.
Right. Which is part of the question you asked, and I want to respond to another part of the question as well, if you don't mind. But to answer that question, we currently have a number of pathway and pipeline programs. I think these need to become less extracurricular and more fundamental to the creation of opportunities for African American and African American women, women from all groups, basically people who would have been excluded by the Flexner legacy. We need to look at that legacy as a structural barrier to this promise of diversity, right? And then we need to look at what diversity means. And so if we have laws that are barring Black people and women from becoming neurosurgeons for decades and decades within the same past century, we need to recognize what those barriers are and make the investment to advance opportunities that break those barriers down, okay? But this is related now to the other component, because it's not just about how many neurosurgeons, right? In any of these countries, whether it's the US or elsewhere, it's where those neurosurgeons are, who are the neurosurgeons as you've spoken to, what are they doing, and the health system that surrounds them. So Paul Farmer often reminded us to think about staff, stuff, space, and systems. So the staff is the workforce question, but then there's the stuff needed to provide comprehensive, safe, affordable, equitable neurosurgical care. There is the space in which this occurs, and there are the systems, pre-hospital, et cetera. And what you're looking at in a Black community, like the communities in Brooklyn that we're referring to, or communities in low and middle income countries like in Haiti, like in Rwanda, like in much of the post-colonial world, you're talking about a problem of intergenerational impoverishment. So there is a generational poverty that constitutes the uphill battle, right? So it's not one grant that does this. So when people talk about reparations, it's difficult to hear that without fully understanding the context. But in fact, there's a generational balance sheet at play here And that balance sheet is killing people. That's what structural violence is. So the way to remedy that is the massive, massive investment. It's the today's version of a Rockefeller investing $180 million in the General Education Board to implement the findings of the Flexner Report. What's that going to look like today? Right? And so it's the advocacy around moving resources so that we can really build the staff and the stuff, the space and the systems that save these lives.
This actually goes to the heart of, thank you so much for responding, because this actually goes to the heart of one of the questions we have. It's from Emily Bacage, and she wants to know if you could speak to the specific needs and challenges associated with neurosurgical care for pediatric patients, particularly in under-resourced areas. And if you're looking at the demographics you shared for Brooklyn and what you just talked about, this is a really good question to answer, and the timing is just right.
Yeah, absolutely. So we saw the data from the Brooklyn Community Foundation. And so we're talking about a community that's dealing with poverty, that's dealing with the insurance context that shows up, which is often, lack of insurance or a Medicaid context. That translates into a lot of coded speak that creates or shuts down access to care, access to pediatric care. Fear of being impoverished by going after a certain brand of care. And so it's not surprising that in some of our communities, when pediatric disease shows up, it gets picked up later, right? That's a reality in low and middle income countries as well as in our communities. And then when it gets picked up, everything that it takes to access that, where are the pediatric neurosurgeons? What kind of center do they need to support everything that they do, right? And then what is that going to mean to the life of the mother or father who's trying to access that care for their child's benefit and still make ends meet? Okay, so I think the resource question becomes critically important then, and it involves even looking at, insurance, Medicare and Medicaid policy, and what's getting covered, what's not getting covered, and who's making the decisions about what's getting covered and what's not getting covered.
Thank you. Dr. Karekezi, any comment on the pediatric neurosurgery experience in Rwanda?
I just echo what Honest just said, but I would just say whether it's pediatric or adults, here everything is a priority. So I'm a neurosurgeon that is trained to do skull-based surgery, but in my daily practice, I deal with pediatrics, I deal with adult, I deal with spine, I deal with everything, because obviously there will be no one to do it. So whether it's trauma is a real issue. Whether it's pediatric is a real issue. Whether it's adult tumors, real issue. I think if you look where we are in our countries, it's the whole neurosurgical care that needs to be improved.
Okay. From the audience, any question from the audience? Yes. Could you speak louder? Wait, I'll give you the microphone.
Hi, thank you both for speaking today. I was wondering, especially for bringing female neurosurgeons globally into the field, how do you both propose tackling the cultural barriers that are there, where in many societies it's perpetuated that a woman should not dedicate 7 to 10 years of her education, or 7 to 10 years to education to become a neurosurgeon because they should be at home taking care of children, and just battling that on a societal level?
Dr. Karekezi, you first.
By coming out and doing it and showing them it's possible. I think that's the only answer, because I did it, a few women did it. I just got married last year. I may not have kids right now, but I know examples of women who went through the training. I'm not saying shorten the training, because then you will not be offering quality training. It's true, neurosurgery is going to require long years of training, and women can do it if men can do it. So we just need more women role models, women who can show that it's possible to the younger generation, and women to whom other young female can look up to and see that everything is possible.
Thank you, Dr. Karakaz. We have a couple of other questions. One from Dr. Thomas Mackey here at SUNY Downstate. As a researcher here at Downstate, I have deeply appreciated the calls and resources available to interrogate the racism embedded in research methodologies like the anthology, White Methods, White Logic. I would love to hear your thoughts about how we decolonize processes of research generation and evidence-based medicine in global neurosurgery.
I'll take that one. Excellent question. So you will hear me frequently come back to reparations. Because I believe it's frankly the solution. The question then becomes how, where does that money go? And I think now you're talking about a question that goes into a fundamental reconsideration of how research funds are generated and moved through the National Institutes of Health. Who is the leadership at the table making those decisions? What is being prioritized? What conversations are people happening? And if I had one of my mentors, Dr. Jean-Luc Cadet, I can only pretend what he might have to offer to this conversation. He's the current chief of molecular neuropsychiatry at the NIH. And he's Haitian American like me, and I've heard him speak to the incredibly challenging context of discrimination he deals with in ivory towers, and trying to have conversations with people who, for instance, won't recognize the absence of data as the reason why something needs to be done, rather than demanding the presentation of data that doesn't exist as the evidence for why something should be done. So, who gets empowered to sit at those tables, have those conversations, and make meaningful decisions about creating grants, for instance, not just at Fogarty, which looks primarily at global health issues and opportunities, but at the National Institutes of Neurological Disorders and Stroke, okay, who would also be very interested, certainly by its mission, in the advancement of health equity in neurological and neurosurgical disease. So, there are small steps forward, like the existence of an Office of Global Health and the affairs of minorities at the NINDS. But it's the question: how much does that office get to have a say in where the R pathway grants and K pathway grants, et cetera, are moving? Is health equity sort of, thrown in as a positive sounding adornment of the goals of the grants? Or is this really starting from the standpoint of health equity is the most important value in what we need to study? Let's create grant funding that allows us to do that. And let's empower the people who are right at the heart of that health equity dilemma to carry out that research. Let's make sure that they have the training to do that research. It takes a transformation of our research and biomedical scientific culture, from the top down or bottom up, to make this happen. And it'll be, very uncomfortable for it to happen meaningfully. But it can also be part of the reparations conversation that I think really advances the ideals of this country, at least by, what has been written that this country, the United States, stands for.
Dr. Karakazi, did you have something to add to that as well?
Yes, Ernest, I wanted to talk about research in global neurosurgery. So looking at neurosurgeon in LMICs, these neurosurgeons are very busy and they have sometimes little research capacities, and they have no protected time to do research. and they will end up not having grants at all. So we actually, after this paper, wrote another commentary about global neurosurgery publication, because there is a big gap. So one big paper that reviewed all papers that were published in the last decade about global neurosurgery. Amongst those papers, there were about 239, if I remember. Only 11% had 3 authors from LMICs, yet, these papers are being written about these countries, and about 28% did not have a single author from LMICs. And this paper are being written about improving neurosurgical care in these countries, yet authors from these countries are not, being part of these plans, or sitting on the table and say, we need this and this, and being co-authored. So, and you'll be surprised, these papers are published in our leading neurosurgery journals. And that's why we're calling for decolonizing global neurosurgery. So it's not just increasing the numbers and providing, improving care. It's also about what we publish. For instance, the US going to publish all papers from Africa, or should African write their own narratives and develop their own research capacities? And I believe programs who come to help our neurosurgeons in LMICs should look into strengthening these research capacities, and they'll leave these neurosurgeons in capacity where they can do their own research, look for their own grants, to look for their own solutions. So that's what we're calling to decolonize global neurosurgery.
Yeah, this bears emphasizing everything Claire just said. The most celebrated global health leaders don't look like Claire and me, and they don't come from the experiences that we come from, right? And so this is one of the things we speak to when we echo some of the ideas of Paulo Freire and his pedagogy of the oppressed, okay? And he spoke, I think, meaningfully to some of these issues. If it is the historically empowered groups that continue to try to solve the global health problems of the historically disempowered, then you haven't actually changed anything about the dynamics of the colonial legacy. What you're doing is you're perpetuating it. And this absolutely needs to be completely transformed if we have any hope to promote social justice.
Thank you, Dr. Barthelemy. We've got one last question.
Yeah, very nicely said. You've just nailed down this session, this special, Black, History Month, decolonizing neurosurgery. You've just answered the question on point. And I thank you, Dr. Karkazika, for bringing that up in terms of the research aspects. Okay, let's take one more question.
One last question before we wrap up. Actually, we'll have 2 questions. I'll just do this one, then we'll take the last question from the audience.
Okay.
Thank you. This question is from Vishnu Khan, and his question is, in terms of neurological ideologies, what is the main composition of a brand coming out to position a structured support?
Will you repeat the question?
Sure. In terms of neurological ideologies, what is the main composition of a brand coming out to position a structured support?
To brand something. Like decolonized neurosurgery could be a brand.
Right.
And could attract some support. Something similar.
Yeah. I think there are a few. So I want to understand the term brand, but I do feel that we're talking about, for instance, the social media space, things like this. And if that's how I'm understanding it, there is a growing movement, decolonize global health. That is, and I've heard in various corners of global health with some welcomed, I would say, controversy that is one call being pushed. So I think we should continue to feed that. I think decolonize global neurosurgery for sure. I think the name of this session is interesting because we're talking about decolonizing neurosurgery, period, right? So decolonize neurosurgery. I think this is another one. I don't know if Claire has any thoughts about this question.
I don't. I don't know what he means.
Thank you for this opportunity to be part of this presentation. I'm not a surgeon or a neurosurgeon or anybody related to surgery. I'm a baby doctor for pediatrics. I happen to be here today helping the coverage, and I just went to this lecture because I couldn't help it, because I've traveled to 23 countries in the African continent out of my own desire, and I've enjoyed my visits to your country in Kigali, in Rwanda, and I managed the language with my tour guide. The purpose of the visit was the guerrilla adventure, but I landed up doing it on the other side, on the Uganda side, in the Buvindi impenetrable forest. So I would like to say I have enjoyed my travels to the beautiful African continent, north, south, east, west, Ghana, Addis Ababa, Egypt, and South Africa, and 20 more in between. And from the pediatric perspective, from the babies, all the images in my phone, and I would love to share them. But right now I'm here, and I'd like to thank you so much for the presentation, and I enjoyed it. Thank you.
Thank you.
Okay, I think we've come to the conclusion of this special session of Black History Month with the title Decolonizing Neurosurgery in Black Communities, a critical conversation about race, ethnicity, and community empowerment in neurosurgical inequities. I think we've met the objective. Thank you to Dr. Claire Karakezi. Thank you to Dr. Ernest Bartholomew for actually making us understand what it means to actually decolonize neurosurgery. And I think it actually applies to everything in medicine. But it's a very good example in neurosurgery, and I think you've laid the foundation for other disciplines to follow. So thank you.
Thank you.